Hello, and thank you for participating in the Hypoglossal Nerve Stimulator Candidate Pocket Review for Primary Care. Brief disclosure, this course is not a comprehensive review of sleep apnea, its management, or standard of care. The scope of this course is to improve referral practices for hypoglossal nerve stimulator implantation. A brief introduction. The goal of this course is to increase education, comfort, and workup for referrals to otolaryngology for hypoglossal nerve stimulator implantation. With that being said, there's a pre-survey and a pre-test, a pocket review educational course, which is this video, along with a calculator introduction, which you will see at the end of this presentation. And it is followed by a post-survey and a post-test. Obstructive sleep apnea can be defined as one of the leading health risks among North American population, with an estimated high prevalence in males of 30% and 15% in females. Airway obstruction can occur both centrally and or peripherally, or a mix of both, and the mainstay gold standard management and positive airway pressure. Delivery can be done by nasal or oronasal positive pressure to maintain upper airway patency of a patient. Health and quality of life risks associated with obstructive sleep apnea include things like hypertension, heart failure, ischemic heart disease, pulmonary hypertension, increased mortality, stroke, arrhythmia, cognitive impairments, and overall quality of life. Basics of sleep studies or polysomnography, or PSG. Obstructive sleep apnea is defined as a cessation of airflow of at least 10 seconds with an effort to breathe. Central apnea is a cessation of airflow for at least 10 seconds without an effort to breathe. Hypopnea, the main definition by the CMS, is defined by 30% reduction in airflow of at least 10 seconds with a 4% oxygen desaturation. Apnea-hypopnea index, or AHI, is a number of apneas plus hypopneas per hour of sleep. PAHIC is equal to the central and mixed breakout. And total AHI is the overall summation of obstructive apneas, central apneas, mixed apneas, hypopneas, and unclassified events. Overall, all scored events of a patient. Continued basics of sleep studies, or PSG. In-lab PSG calculates AHI based on total sleep time. Home PSG calculates AHI based on total recording time, not total sleep time. It can underestimate the AHI of a patient. Contraindicated in pediatrics patients, suspected central apnea, or severe medical comorbidities. Split night PSG includes a CPAP trial during the study. Basics of differentiation in adults: normal AHI less than 5, mild AHI 5 to 15, moderate 16 to 30, and severe greater than 30. For pediatric patients, it can be stratified in a slightly different scale. Pediatrics, normal is less than 1 AHI, mild is AHI 1 through 4, and moderate is 5 to 10, and severe is AHI greater than 10. Upper airway basic anatomy. It can be divided into different sections, for example, the nasal cavity, and then what we define as VOT, or velopharynx, or pharynx, base of tongue, and epiglottis. It can have multi-level obstruction contributing to OSA or to positive airway pressure tolerance based on the different levels of obstruction. Nasal cavity includes things like the nasal septum, nasal turbinates, nasal airflow. VOT, defined as velum or soft palate, oropharynx, tongue base, and epiglottis. What if they cannot tolerate PAP? Compliance and tolerance is defined as 4 hours per night on 5 nights per week. Examples of reasons for non-compliance include claustrophobia, facial pain, facial ulcers, facial rash, discomfort, too much pressure, nasal congestion, too loud, or even mask leak. Non-surgical adjuvants to OSA include different types of masks, as shown here: nasal flow mask, full face mask. Continuous positive airway pressure, CPAP, and bilevel positive airway pressure are the two main types of masks used. BiPAP classically helps patients with too much pressure, and you can consider discussion with sleep medicine titration provider for alternate mask. To improve tolerance, you can consider other adjuvants like nasal strips or oral airways, oral devices, weight loss, side sleeping, or body-forming pillows. On the other hand, surgical adjuvants to ASA examples can be divided in for the nasal cavity, things like septoplasty, turbinate reduction, adenoidectomy, sinus surgery if the patient has polyp disease. However, generally, these are not curative, but it can help improve PAP tolerance. To move on to the vote section, you can have maxillomandibular advancement, palatoplasty, pharyngoplasty, lingual tonsillectomy, base of tongue ablation, genoglossal advancements, but we will focus on the hypoglossal nerve stimulator. A drug-induced sleep endoscopy, or DISE, is the first step to be further evaluated for hypoglossal nerve stimulator. It simulates sleep and helps surgeon identify areas of obstruction by inserting a camera through the nose to evaluate the upper airway. Concentric collapse at the velopharynx of the soft palate makes a patient not be a candidate for hypoglossal nerve stimulator implantation, as depicted here on the image on the left. Pathway to hypoglossal nerve stimulator implantation. A patient presents to primary care clinic. Patient is then evaluated, and positive airway pressure intolerance is identified. Consideration for referral to an otolaryngology clinic is identified for further evaluation. And if an overall workup is complete, which would be reviewed in the next slide, and the patient is generally a candidate with the exception of evaluation by a drug-induced sleep endoscopy, the patient can be taken to the operating room to move on to the step of a DISE. If the patient is a candidate, then the patient moves on to the upper branch, where the operating room can be set up for a hypoglossal nerve stimulator at a different date. And if they're not a candidate, and they could be a possible candidate for other alternative surgery as discussed previously. However, if a workup is not complete, then they fall into this other branch of this pathway, and that includes referrals for PSG or weight loss if they don't meet the minimum criteria by BMI, and then you wait, you reevaluate, and the patient then goes sees either otolaryngology clinic or their primary care. If a workup is complete, but the patient is generally not a candidate, the operating surgeon may opt to further evaluate for additional or alternative airway surgery such as septoplasty, which will help improve PAP tolerance, or palatoplasty as another example. What is a workup and who is a candidate? Workup includes a PSG within 24 months of ENT evaluation generally, in-lab sleep study if there is a concern for underestimation in a home sleep study. Need a PSG breakdown of obstructive, central, mixed apneas, and unclassified events in order to calculate total HI. Weight loss management if the patient is over the BMI goal. A patient is considered a potential candidate prior to DISE if they have the inability to tolerate PAP. Other criteria include older than 18 years of age or older than 13 years of age in a patient with Down syndrome, but with AHI greater than 10 but lower than 15 do not have the ability to benefit from CPAP. For adults, greater than 15 AHI or greater than 15 AHI despite PAP usage, less than 25% central or mixed component of total AHI with a calculation of the total AHI, and typically less than 35 BMI depending on insurance. And no complete concentric collapse at the level of the velum on a DISE evaluation. Hypoglossal nerve stimulator implantation basics. It is a 2-incision outpatient surgery approach. The chest incision allows for the implantation of a breathing sensor, which then is connected to an electrode that is tunneled through the neck for the other incision, which wraps around the hypoglossal nerve, which provides a stimulation cuff. At this point, there can be unhindered protrusion of a stiffened tongue with stimulation of the hypoglossal nerve, and the respiration sensing lead to coordinate with breathing of the patient. This can all be controlled remotely postoperatively. What to do? A lot of information has been provided, but a patient then presents to your primary care clinic and you have all this data to decipher and to interpret. It is too much to remember. That's why we've created the Hypoglossal Nerve Stimulator Pocket app. This app allows to simplify all the data and information that was provided here today by simply inputting the patient's information onto the app. The app is intended to be straightforward. You can input today's date, which will help calculate the date from today to the date of the sleep study. Patient age, if the patient has Down syndrome or not have Down syndrome. To evaluate the tolerance of PAP, so number of days per week. Hours per night use of PAP. Date of last sleep study, which can then be calculated of how far along or how old the sleep study is based on today's date. Type of sleep study that was done. BMI of patient. AHI or PAHI. No positional apneas. Non-positional hypopneas. Non-positional or unclassified events. Central apneas. Mixed apneas. PAHIC. And then the app will automatically auto-generate total apneas and then a total AHI. This is an example of the results that can be provided. The app provides general information or recommendation about workup that can be done prior to evaluation by an otolaryngologist, as options include updating a patient's prior sleep study or consider referral to weight management. Implantation of the app in your practice can potentially improve the number of patients that present to otolaryngology clinic for evaluation with a completed workup and up-to-date workup prior to for further evaluation of a surgical adjuvant to obstructive sleep apnea.